Hello, everybody. I'm Heinrich Heimann from Liverpool, and together with Jens Kiilgaard from Copenhagen, I'm really pleased that we can have this ocular oncology seminar within EURETINA. Just a couple of housekeeping issues. We have some fantastic talks from European and world leaders in the field. We then have two case presentations from the younger members of EURETINA, which I'm very proud to involve them into the program. If you have questions, please put them in the Q&A session in the bottom of the screen. We try to answer a couple of them, but we won't be able to answer all of them. But I will ask the speakers to answer them in writing at the end or shortly after the session. So please keep an eye on the answer that might flock up later. We have a polling as well in the case presentations, and then the polling window will pop up at the bottom of your screen, so you can answer that. And I'd like to ask Jens to give some introductory words.
Thank you, Heinrich. So, small melanocytic lesions in the posterior pole is a well-known problem, and it was a great pleasure for us to be organizing this webinar, which hopefully will gain some information that can help the normal retinologists in dealing with these small lesions. And the first speaker will be Professor Nikolaos Bechrakis from Essen Oncology Department, Ocular Oncology Department. And he will give us a small introduction in how to differentiate between the small melanocytic lesions we find in the fundoscopy session. So please, Nikolaos, the word is yours.
Thank you very much. Thank you. So thank you, Hanno. Thank you, Jens, and I'm glad to join this prestigious session. My topic is back to school, where this is a quite difficult issue, but anyhow, I'll try to do my best. And this is live now, so I'll try to keep up with the time. When we talk about pigmented lesions of the eye, there are different cells of origin. These are melanocytes, and these can be pigmented epithelial cells. And as you know, melanocytes can be conjunctival, episcleral, scleral, or uveal, but they can, and the pigmented epithelial cells can be in the iris, the ciliary body, or the retina. And in terms of where they are derived from, melanocytes are derived from the neural crest, and pigment epithelial cells are derived from the neuroectoderm. So in order to understand really what the difference is, we need to go back to school and back to embryology. So we need to understand what is gastrulation, and this is the ectoderm, the mesoderm, and the endoderm back here. And during gastrulation and the process just afterwards, the so-called neurulation, we have the development of the neural plate. Further on, with the different signaling pathways that you can see here, there is a neural fold and a neural groove, and just after that, in the third, fourth week of gestation, we have the development of the neural groove, and further on, the neural crest here that you can see here. And these pathways are very essential to understand what are the drivers to develop the neural crest in contrast to the neural tube. From the neural tube and the neural crest, specifically the neural crest, the development of smooth muscle, osteoblasts, adipocytes, chondrocytes, neurons, swan cells, and melanocytes. So they are neural crest derived in contrast to the neural tube, where the neuroectoderm develops to the optic vesicle, as you can see here in around day 28 in a very old slide from Innsbruck. So from the optic vesicle, we have the development of the neuroretina in the outer portion, the retinal pigment epithelial cell that is also a pigmented cell layer, but on the outside we have the development of the choroid and the sclera that gives rise to melanocytes. And you can see this in this sagittal section, where you can see the RPE is developed by the outer portion of the neuroretina, and the melanocytes are from the outer portion, the choroid. So going back to the clinic now, RPE pathology is completely different than the melanocyte pathology, where we have congenital lesions, degenerative lesions, as we all know, AMD, for instance, the most common, but also reactive metaplasia. And actually, neoplasia, so tumor development, is very rare from the retinal pigment epithelium. Just to give you some examples of congenital lesions of the RPE, it's a simple hematoma of the RPE, combined hematoma of the retina and the RPE, and congenital hypertrophy of the RPE. Just to see what the congenital simple hematoma has been described by Don Gass many decades ago, before the development of OCT, and you can see how precise he was in his description in comparison to the OCT nowadays. Most importantly, the congenital hypertrophy of the RPE. It is this jet black lesion of the retinal pigment epithelium, where you can see the hypertrophic retinal pigment epithelium that is just a single layer of hypertrophic cells that are densely packed with melanin granules. And in some occasions, these can be accompanied by hyperplastic cells as well. And in very rare occasions, these hyperplastic parts of this can give rise to a neoplasia that can be an adenocarcinoma of the retinal pigment epithelium that is also can be called malignant epithelioma. So again, pigmented lesions of the fundus can be either from the RPE or melanocytic. And in terms of melanocytic, we have the benign melanocytes. These can develop to nevi, these can develop to melanoma, and even from melanocytes, probably directly development to a melanoma. The driver for this has been identified in the past years as being GNAQ and GNA11 mutations that can give rise from a melanocyte to a nevus. And in this slide, you can see a cross-section through a nevus that is here on the bottom, and a melanoma in the same eye that are different, the one from the other. And just to give you a histologic example of this, you can see on the right-hand side here, the edge of the nevus that are slender spindle cells. You can see the typical drusen just above that, and the densely packed nevi around a normal choroidal vessel. Going further, melanocytoma is a special case of a nevus that is also called a magnocellular nevus. We know this pathology of this jet black lesions on top of the optic disc or around the optic disc that are even within the retina. And if we look at the true pathology of these after bleaching of these very black pigmented cells, you can see that these are completely benign cells. And in a very rare occasion, even these can be transformed into uveal melanoma, but this is a rare occasion. So we have described this many, many years ago, and Bertil was there about 30 years ago in Glasgow, that there is a transformation of a nevi to a melanoma in iris melanomas, and some 10 years later, we even described sorry, I have to go back. The transformation of spindle cells melanoma to epithelioid melanoma, giving a de-differentiation potential of these cells and an evolution from spindle cell to mixed cell to epithelioid cell. And what this means in genetic terms probably has to do with the mutations that have been identified in the last 10, 20 years as being in the first hand a GNAQ11 mutation and as an initiating signal, and then a mutation either at the IFX gene to give rise to a class 1 melanoma, or on chromosome 3 monosomy or BAP breast cancer associated protein 1 mutation to give rise to class 2 melanoma that is highly associated with metastases, whereas class 1 melanoma can have a late mutation with SF3B1 gene and to give also rise to tumors. So in summing up this whole issue, very, very briefly, their pigmented lesions of the fundus can be discriminated either being neuroectodermal derived, being an RPE. This is the benign CHRPE lesion, or can be derived from melanocytes that are derived from a neural crest that can give rise to nevi or melanomas. That was it. And thank you very much for your attention.
School or back to
yeah.
Back to university, I would say, not back to school. Fantastic talk. Just a quick question. As far as I understand, the more pigmented races and Caucasians have pretty similar RPE, but they vary in the melanocytes in the choroid. Now, how does it explain the differences in malignancies? Do you have any idea, or is there any idea of anybody behind that? Why?
Sorry, I don't know. I don't know the answer to this question. So, but it is absolutely a valid question. Why do people who have more melanocytes have less propensity to melanomas? I don't know. But we know that patients that have a melanosis oculi, they have a much higher probability of developing melanomas. But I always thought this has to do with the amount of melanocytes.
Okay, brilliant. Thank you very much. Just to the audience, please put your questions in the Q&A session, and we will try to answer them later or during the next talks. Now, it's my great pleasure to introduce Carol Shields in our Global Superstar slot. And I really have to say, this is absolutely fitting. And forgive me if the other oncologists are online. I think probably she's the most influential ocular oncologist at this stage. And all I can say is what I do at the moment every day. We don't have a melanoma detector or anything in our clinic. What I do is exactly what you will hear in the next 10 minutes. I just follow the rules that Carol set up with her group. So I'm so pleased that we can present her presentation here. Thank you so much, Carol.
And I'd like to talk to you about smart imaging of choroidal nevus and how it works. So this is a small juxtapapillary nevus, right? But does this orange pigment bother you? And this subtle puddle of subretinal fluid? And if we look at autofluorescence, we can see the orange pigment and the fluid much better. And on OCT, the subretinal fluid is noticed. Do these features bother you? Well, this lesion had evidence of growth between 2009 and 2014, signs of activity with the orange pigment and subretinal fluid. This is probably an active melanoma and not a choroidal nevus. Multimodal imaging of choroidal nevus can help us to identify high-risk features of a nevus and perhaps identify small melanoma at a very early point. For example, in these two photographs, you see a choroidal lesion, same size, but the one on the left has overlying drusen and RPE loss consistent with nevus. The one on the right has overlying orange pigment and shallow subfoveal fluid, more consistent with melanoma. So 4 questions. Does imaging help with identification of choroidal nevus with risk factors for melanoma? The answer is yes. Question 2, are outcomes different based on various combinations of risk factors? Yes. Does choroidal nevus thickness matter? The answer is yes. And number 4, is the rate of nevus transformation the same or different based on the patient's race? It's the same, it's no different. So in the past, we judged choroidal nevus risk factors based on clinical evaluation. We would say, it looks like orange pigment, it looks like there's subretinal fluid, but now we judge it based on imaging modalities, where we are sure there's orange pigment and we are sure there's subretinal fluid. So let's look at question number 1. Does imaging help with identifying choroidal nevus with risk factors for growth to melanoma? In the journal Retina 2019, we evaluated choroidal nevus imaging features in 3,806 cases and risk factors for transformation into melanoma using these imaging features. Imaging was performed in every case and used in the calculations of risk factors. Now, in our practice, we see very suspicious nevi. And in our practice, we found on follow-up, 1% of choroidal nevi show growth into melanoma by 1 year, 6% by 5 years, and 14% by 10 years. This is greater risk of transformation than is seen in the real world. But in our practice, we found 6 risk factors, and we remember them by the mnemonic to find small ocular melanoma doing imaging, where each one of those letters represents a feature. For example, the T stands for thickness over 2 millimeters, the F for subretinal fluid on OCT, the S for symptoms of vision loss on Snellen acuity, the O for orange pigment on autofluorescence, the M for melanoma hollow on ultrasound, and the DIM for diameter greater than 5 millimeters on fundus photography. And if you look at these 6 risk factors, they're all highly significant, and thickness over 2 millimeters on ultrasound, fluid on OCT, and orange pigment on autofluorescence imparts the greatest risk for transformation. Now, when a patient comes to see us, we get a visual acuity using the Snellen acuity chart on everyone. We always take a fundus photograph, and we tend to do autofluorescence and ultrasound on any lesion that has thickness, and we get an OCT. This is just our routine in imaging for choroidal nevus and for choroidal melanoma. Okay, cool. So what is the impact of 1, 2, or 3 risk factors? Well, if a patient has 0 risk factor, the chance for growth into melanoma is 1% by 5 years. Any 1 risk factor imparted an 11% risk for growth. Any 2 risk factors, 22% risk for growth. And any 4 factors imparted greater than 50% chance for growth by 5 years. So usually we use greater than 4 risk factors as our cutoff to treat a patient promptly, rather than waiting for growth. So let's put it to work and score these lesions. Now this lesion here is less than 2 millimeters in thickness. So these are very thin lesions, but I just want to show you how this works. This lesion, if we look at the risk factors, TFSOM, DIM, this lesion is 1.4 millimeters in thickness. So thickness is negative. But we have subretinal fluid that we can see on OCT, orange pigment on autofluorescence, but we don't have any acoustically hollow mass on ultrasound. This lesion had 3 risk factors: fluid, symptoms of vision loss, and orange pigment. That's a 34% chance for growth within 5 years. Here's another thin lesion. It's only 1.8 millimeters in thickness, and we have our 6 risk factors. And if we look at this lesion, we see it's very thin, so it doesn't have thickness risk factor. But on OCT, we have subretinal fluid. On autofluorescence, we have orange pigment. And on ultrasound, we have a hollow appearance to the mass. And this mass is 5.5 millimeters in diameter. So we have 5 of 6 risk factors. That's a 55% chance for growth within 5 years using Kaplan-Meier analysis. That's a lesion that we would have treated promptly, especially knowing that this is a 30-year-old man. And on the top 3 images, you can see that the lesion at presentation, and then on the bottom 3 images, 2 years later, following plaque radiotherapy, the orange pigment has resolved and the subretinal fluid has resolved. Plaque was placed directly over the tumor with protection of the macula using specifically aligned radiation seeds. Okay, question number 2, are outcomes different based on various combinations of risk factors? So we published this in the British Journal of Ophthalmology 2019. Combination of multimodal imaging features predictive of choroidal nevus transformation into melanoma. And we made a heat map where the blue or green impart lower risk, and the orange and red impart highest risk for growth. And in this heat map, you can see all the 60-some various combinations of 6 risk factors. And some of these risk factors imparted greater than 70% chance for growth within 5 years. This heat map we keep in every examination room in our office, so we can get a precise estimate of risk for transformation of nevus into melanoma, because we see so many patients with risky nevus. This is huge for artificial intelligence, and currently we are working on that. So here's a patient. Is this a nevus or a melanoma? Well, on autofluorescence, we can see orange pigment, and on OCT, we can see obvious subretinal fluid. This patient had 4 risk factors: thickness over 2 millimeters, fluid on OCT, orange pigment on autofluorescence, and melanoma hollow on ultrasound. That was a 40% risk for growth by 5 years. We treated this as a melanoma. And initially, we treated him with a new nanoparticle therapy, R011, but the tumor still grew. So then we needed to treat with plaque radiotherapy. And here's another one, a similar lesion. This lesion, you be the doctor, this lesion on autofluorescence has orange pigment with even a puddle of orange pigment. on OCT, there's subretinal fluid and the lipofuscin can be seen in the subretinal space. There were 5 risk factors here: thickness, fluid, symptoms, orange pigment, and hollowness in ultrasound. And that, based on our heat map, has a 100% rate of growth by 5 years. This patient was classified as melanoma and was treated promptly. Okay, third question, does choroidal nevus thickness really matter that much? The answer is yes, it matters greatly. So the 5-year rate of growth, we published this in Retina 2019, choroidal nevus transformation into melanoma per millimeter increment in thickness using multimodal imaging in over 2,000 cases. So what is the 5-year rate of growth for a choroidal nevus 1 millimeter or less in thickness? It's less than 1%, it's 0.8%. How about if a nevus measures 1 to 2 millimeters in thickness? It's still low, it's only 2% rate of growth. But look what happens when a tumor crosses 2 millimeters in thickness. Those nevi that are 2 to 3 millimeter in thickness have a 25% rate of growth. So we use this as an important cutoff where the risk for growth escalates. And last question, is the rate of nevus transformation the same or different based on patient race? Morris et al. From our team answered this question in the Indian Journal of Ophthalmology 2019, malignant transformation of choroidal nevus according to race in over 3,000 patients. And we asked our question, does it differ based on race? And we found that Caucasians have older mean age at presentation, more female sex predilection, lower frequency of dysplastic nevus, higher frequency of cutaneous melanoma, and nevus multiplicity per eye. But we found Caucasians versus non-Caucasians, there was no difference in the rate of transformation, 2% versus 3%, and it was not significant. So despite few dissimilarities in presenting features of choroidal nevus in Caucasians versus non-Caucasians, there was no difference in the rate of nevus transformation by race. So in answer to these questions, yes, imaging does help with identifying choroidal nevus with risk factors for growth to melanoma, and the main imaging modalities we like to use include ultrasound, OCT, and autofluorescence. And then regarding outcomes difference based on various combinations, yes, there are over 60 combinations of these risk factors, but I would beware the combination of thickness over 2 millimeters, fluid on OCT, and orange pigment on autofluorescence. That's a bad combination, giving a high rate of transformation. And does choroidal nevus thickness matter? Yes, especially if the nevus is over 2 millimeters. And does nevus transformation rate differ by race? And the answer is no difference. It does not differ by race. So if you had this lesion, would you want your doctor to say, there's a risk for melanoma here, but I really don't know. Come back and see me in 6 months and we'll see. It might be bigger. Or would you want your doctor to say, this is a melanocytic tumor with a 34% chance for growth in 5 years, knowing that we might consider treatment promptly. Now you be the doctor with this final case. We can see the orange pigment. It's 6 millimeters in base. And if we look at risk factors, we have diameter greater than 5 millimeters, obvious orange pigment seen on autofluorescence, obvious subretinal fluid on OCT. Patient has decreased vision from that subretinal fluid, and the lesion is 2.5 millimeters in thickness, greater than 2 millimeters, and plus minus acoustically hollow. So this patient has 5 of 6 confirmed factors with a 55% rate of growth by 5 years. This is how we use multimodal imaging. So in conclusion, remember the mnemonic: to find small ocular melanoma, doing imaging, 6 risk factors. The T stands for thickness over 2 millimeters on ultrasound, F for fluid on OCT, S for symptoms of vision loss on Snellen acuity, O for orange pigment on autofluorescence, and M for melanoma hollow on ultrasound, and DIM for diameter greater than 5 millimeters on photography. Thank you.
So thank you, Carol. Again, a very inspiring talk. And I, as Heinrich, use TSFMO Memnonic every day in my clinic and also teaching other oncologists. But often I get a question, what if I have a patient with no risk factors? How often would you follow such a patient? Or should I follow him or her at any point? Or could I just stop?
Sure, that's a good question. I apologize for how fast my video ran with my fast-paced discussion, but I had to squish it into the time. Regarding a patient who might have no risk factors, we still follow these patients. We would probably see them initially back in 6 months just to confirm it's stable. That provides peace of mind for the patient. And then if it's stable at that point, probably check them once a year. We generally share visits with a referring doctor. So the referring doctor might see them in 6 months, and we would wait for an entire year before we see them back. So initially 6 months, then after that, once a year. On every patient we see, we write down the 6 risk factors, TFSOM, DIM, and we mark if it's positive or negative. So we know what we were thinking when we first met the patient, how risky it was or how non-risky it was.
Thank you. Due to time, we have to move on to the next speaker. And when we talk about ocular oncology in Europe, it's impossible not to mention Bertil Damato, which has been a great inspirer for many of us younger oncologists. He has been working a lot of trying to make us understand how this disease works and how the patients actually live with that disease. So Bertil, please enlighten us on your mole system.
It's a great pleasure to give this presentation, and I'm very grateful for the invitation. I developed moles to help non-experts estimate the likelihood of malignancy in melanocytic choroidal tumours, to avoid unnecessary clinic visits and investigations while expediting the referral of patients with melanoma. Moles stands for mushroom shape, orange pigment, large size, enlargement, and subretinal fluid, all of which are well known to be indicators of melanoma. Mushroom shape is scored as 0 if absent, 1 if incipient, and 2 if present with overhang. Orange pigment is scored as 0 if absent, 1 if uncertain, or if only dusting is present, and 2 if definite and confluent. Large size is scored as 0 if tumor diameter is less than 3 disc diameters and thickness is less than 1 millimeter, 2 if diameter is more than 4 disc diameters, or if thickness is more than 2 millimeters, and 1 if measurements are something in between. Enlargement is scored as 0 if absent, 1 if uncertain, and 2 if definite. If a tumor was not mentioned or documented in previous examinations, it is scored as 1 if no imaging was performed, and 2 if its absence was confirmed photographically. We found that tumor progression is almost always evident without ultrasonography, which is important as ultrasound is not widely available outside specialist clinics. Subretinal fluid is scored as 0 if absent, even if there is intraretinal fluid, 1 if visible only on OCT, and 2 if visible ophthalmoscopically. Tumors are categorized as common nevus, low-risk nevus, high-risk nevus, and probable melanoma according to whether the total moles score is 0, 1, 2, or 3 or more. The reason for the term probable melanoma is that non-experts may not feel comfortable diagnosing melanoma and differentiating this from other tumors, such as hemangiomas and metastases. My colleagues and I have designed PDF and Word versions of the referral form, which provide all the information that is needed to refer patients appropriately and safely. Here is a probable melanoma with a score of 4 because of orange pigment that is confluent, diameter between 3 and 4 disc diameters, and traces of subretinal fluid. Notice how this 5-digit code succinctly conveys very much information. Here is a common nevus with a mole score of 0. Contrary to previous impressions, proximity to optic disc is not a strong indicator of. Here is a small melanocytic choroidal tumor, which looks as if it has confluent orange pigment on most of its surface. But fundus autofluorescence imaging shows no bright hyper-autofluorescence, which indicates that the pallor reflects a melanotic tumor that is visible through transparent retinal pigment epithelium. Here is a choroidal melanoma with desquamation of the lipofuscin, which has drifted through the subretinal fluid to settle inferior to the tumor, forming a pseudohypopian type of appearance on fundus autofluorescence imaging. Here is what looks like a common nevus in a middle-aged woman. However, previous imaging confirmed that this tumor was absent 5 years previously, indicating that this tumor should have a Moles score of 2 and that it should be considered as a high-risk nevus and monitored very closely. Here is definite growth of a nevus in a child. Although nevi normally grow in the first 2 or 3 decades of life, these patients need to be monitored until tumor growth stops, because some melanomas do develop in early life. Here is a low-risk nevus with a score of 1 because of its diameter. Here is a high-risk nevus with a score of 2, with possible or probable dusting of orange pigment and a trace of subretinal fluid. This nevus shows cystoid intraretinal edema, which is a sign of chronicity and which is therefore given a score of 0. Here is a probable melanoma that has perforated the retina. Moles does not apply to melanocytoma and congenital ocular melanosis because all these patients need to be monitored indefinitely for malignant transformation to melanoma. The Moles score was developed at Oxford and then validated by Al-Harbi et al. At Moorfields in London. All 81 tumors diagnosed by experts as melanoma had a Moles score of 3 or more, giving a sensitivity of 100%. In the 141 tumors diagnosed as nevi, only 6 had a Moles score exceeding 2, giving a specificity of 97%. Here are the 6 discrepant tumors. I think ocular oncologists would probably debate amongst themselves whether these tumors are benign or malignant. In another study at Moorfields, Reloff et al. Looked at 451 tumors that had been treated as melanoma. All but one of these had been given a score more than 2. Here is the discrepant case. Whether the failure occurred because of moles or whether it was poor documentation of retinal detachment, I can't say. In conclusion, moles should help non-experts estimate the risk of malignancy in melanocytic choroidal tumors and manage patients accordingly. However, non-experts need to be able to examine the eye and to recognize all the relevant clinical signs. Thanks to advances in teleophthalmology, experts can remotely advise on diagnosis and management without ultrasonography. I would like to acknowledge all my colleagues, past and present, and I would like to thank you for your attention.
Well, thank you, Bertil, as usual, an absolutely fantastic talk. And perhaps I ask a question to you and then to Carol to get the US perspective. In the UK, we really have problems that the ultrasound seems to be broken in so many departments that avoiding the ultrasound for our risk assessment is a big step forward on the one hand. Perhaps, Carol, you can comment on that as well. But one question I'd like to ask both of you, Bertil first and then Carol. Orange pigment when it's typical, it's typical. It's, you know, like these cow-shaped plaques of orange pigment, but sometimes you just have a granular appearance on autofluorescence and you can't really see clinically that there is orange pigment. Can you comment on what to you is orange pigment and what not really? Perhaps Bertil first and then Carol.
If the examiner is not sure whether or not there's orange pigment, but is suspicious, then the score is 1.
Mm-hmm.
Or if they're sure that there's orange pigment, but it's only dusting, that's a score of 1 too. But if there's clumping, then there's a score of 2. What my referral forms, the referral forms that I've designed, the PDF, if you hover over the text, then tips appear as to how to assess orange pigment and so on, to make it easier for non-experts to have the knowledge they need without having to refer to a textbook or to an article or whatever. The information comes out of the referral form.
Thank you, Bertil. And Carol, what are the rules in your house?
Yeah, thank you for that question. That's a really good question. And I think it applies to orange pigment, but also to subretinal fluid. Is this active fluid or is this just a cleft of fluid? And it also applies to hollowness on ultrasonography. Is it truly hollow or is it a little more dense? These are all judgmental calls. Even though we think we're using imaging and we're more scientific with our imaging, we're getting one level of higher quality judgment of choroidal nevi, but there's still the unknown. So in our practice, we like to see what we call geographic orange pigment. You can actually clinically see it. And when you look at the autofluorescence, it's very geographic over the surface of the tumor. I realize what you were pointing out, that sometimes you'll see a little bit around the edge of a nevus. We wouldn't classify that as orange pigment. We like to see it over the surface of the tumor.
Well, thank you both so much. Just one outline again, if the presenters also could look in the Q&A session, there will be some questions coming. If you could answer them, I would be most grateful. And that leads us over to the case discussion, and Jens is going to lead into that. Thank you both so much.
Yeah, it's a great pleasure to introduce Niels Brouwer from the Leiden University Hospital. He is one of our younger colleagues, and he would like to present a case which we normally meet as a struggling case. But Niels, please enlighten us.
I can't hear him. Can you hear him?
No.
I'm so sorry. Can I be heard?
Yeah.
Yes.
Oh, we can
yes.
hear you.
Perfect. Okay.
Okay.
So it's about a male patient of 68 years old who was referred to our institution by a local ophthalmologist with a choroidal pigmentation that was detected during an ocular screening program. The patient had no visual complaints. He had a history of cardiovascular disease, but no other relevant comorbidity. Had a very good visual acuity of better than 20/20 vision. And with fundoscopy, we noticed a choroidal pigmentation with some orange pigment, no drusen, no halo, and no subretinal fluid, as can be appreciated here on this photograph. And so my first question for the audience would be, what would you do next? So if you could go to the polling system, please, and give us an answer. First option could be to return the patient to the local ophthalmologist and advise revision in about a year's time. Should you review the patient in 3 months' time in your own clinic? Or would you first perform further imaging, such as with fluorescein angiography and ultrasound? Okay. I think we can close the poll by now. And so the majority of the participants, well, provided the answer that I would agree with. First, to perform further imaging. And so this is a fluorescein angiography of our patient. And we notice here the choroidal lesion with some pinpoint leakage, which can be seen by the small white dots. And also with ultrasound, we noticed a mid or high reflective lesion of about 1.5 millimeters tumor height and basal diameters of somewhat over 6 and 3 millimeters. Now, the second question with this new information would be, what is your diagnosis and your suggested treatment? So again, please provide your answer in the poll. Is this a choroidal nevus that should be reviewed in 6 months' time? Or is it a choroidal melanoma that requires plaque and brachytherapy? Or could it be either? Okay, and I think we can close the poll by now. And okay, about 70% of patients, participants answered that it is a choroidal nevus. Well, it may be a bit of a trick question because we suggest it could be either, and we deem this lesion a suspicious choroidal pigmentation. Now, of course, the treatment of this lesion is a bit of a delicate matter. It's a rather small lesion, and of course, due to the location being so centrally in the eye, radiotherapy would, of course, cause vision loss. And we discussed all this with the patient, including the very small risk for metastases in this small lesion. And our patient actually preferred to first have watchful waiting. He really wants to retain his good visual acuity over the treatment of a lesion that might metastasize in a very small number of cases. So in this process of shared decision, we decided to follow up the patient in 4 to 6 months. Now, several of these follow-up visits followed, and the patient had no visual complaints. The lesion remained unchanged in size and other characteristics. And we were actually quite pleased with our management of watchful waiting. And so the question, of course, could be asked, can we just sit back? And is that it? But unfortunately, that was not the case. And 5 years after the original diagnosis, the patient started to notice a decreased vision. Visual acuity went down to about 20/30. And with fundoscopy, we noticed that the choroidal pigmentation had increased in size. And also with the OCT of the macula, we noticed that subretinal fluid was present by now. Using the fluorescein angiography, again, we noticed the lesion with, again, the pinpoint leakage. And with ultrasound, this was now a ultrasound hollow lesion with a bit larger size with tumor height of 2.2 millimeters. Now, again, we discussed the treatment options with our patient. Treatment, radiotherapy, of course, would influence the visual acuity, but the tumor had demonstrated significant growth by now. And of course, further waiting could eventually limit the possible treatment options in this case. So by now, the patient was treated with plaque and brachytherapy.
Oh, thank you very much. And this is a case we really see in everyday life. Nikos, nevus or melanoma, going back to your talk, do you think this was a nevus for 4 or 5 years that then got a kick and turned into a melanoma? Or would you tell me that is more likely to be a melanoma that is slowly growing over the years? That would be quite important for the follow-up, because if it's a slowly growing melanoma, we have to get better at picking up changes. What do you think?
Yeah, well, I do agree. I mean, we use Carroll Shields rules in everyday clinic. So I would have said that this is a nevus in the first place 5 years ago. But I would probably say that this is a high risk nevus. So I would prompt and go on for follow up every 3 months, maybe every 6 months in our clinic, and every second time in the referral ophthalmologist, in order to see any changes as early as possible and then treat it whenever you have more risk factors. And probably we would not treat it by brachytherapy, but by proton beam irradiation when we have seen the first changes in size and reflectivity.
Carol, what are your comments regarding this? Would you done if something differently?
Well, I think the management was good based on, what imaging modalities they had. The thing that bothers me is there were little pinpoint leaks on fluorescein angiography. And if you have those leaks, you got to have subretinal fluid. But we didn't have an OCT from the start. So this is where having an OCT and autofluorescence from the start may have picked up maybe a tiny bit of orange pigment or a little bit of subretinal fluid. So it may have guided us along the way. But I think their management, I totally agree with the management, given the fact that they didn't have autofluorescence and they didn't have OCT from the start. We would have put the patient from the start through all the imaging.
Bertil, where would the mole system come in here?
I was counting the mole score as the talk was going, and
I knew you would.
and it was a high-risk nevus with all that orange pigment and the thickness and so on made it probable melanoma to me.
Niels, any comments at the end?
So no sound, Niels?
Okay, so
Yeah.
Thank you for the comments. I think, well, my apologies for the digital problems. The thing I also wanted to highlight in this case was, of course, the decision-making process with the patient, because it's either nevus or a melanoma. So it's very important to weigh in the opinion of the patient regarding the weighting or the more aggressive treatment. And that as an oncologist, you should really ask for that in your patient as well, besides the technical aspects of the characteristics of the lesion.
Bertil, one comment still?
When I was working with you in Liverpool, used to do biopsies on these small tumors.
Mm-hmm.
What do you think about that?
Yeah, I think that will be for another seminar, really. But yes, I agree. Thank you so much. I think the one imaging method we need is a retroscope in our clinic, and then we would have no problems diagnosing all these lesions correctly. So that leads over to the next case from Hibba Quhill from Moorfields Hospital. Hibba, please.
Thank you very much for the opportunity to present a case from our experience at Moorfields Eye Hospital in the United Kingdom. I'd like to present a 20-year-old female who asymptomatically presented to her optician with this small juxtapapillary pigmented lesion in the left eye. She had no relevant past medical history, but had a family history of a grandfather who was enucleated for an eye tumor, and her visual acuity at presentation was excellent. This brings us to our first poll, which you should be able to see on the right-hand side. If you had been the clinician seeing this patient at this first examination, what would you have done? Would you have discharged the patient without any follow-up? Would you have discharged them to the local optician for annual review? Organised annual hospital eye department review? 6 monthly hospital eye department review? Or would you have urgently referred to an ocular-oncology specialist? We'll give the poll a few moments. And I'm ready to close the poll when you are. So interestingly enough, the majority of our listeners today have fallen towards the more aggressive surveillance option. I think that most clinicians would describe this as a very small pigmented lesion, perhaps even just a freckle, and called it a benign choroidal nevus. And we would suggest that you could discharge this patient to the local optician for review. The optician very diligently followed up this patient and performed sequential photography and saw the patient almost annually. It's something for you to consider. If you had been the optician reviewing this patient, at what point would you have intervened and done something other than bring the patient back next year? In our case, you can see the sequential photography shows that the lesion grew to being almost quadruple in size. The optician in question referred the patient in 2021, and the patient was seen by the hospital eye service specialist who quite rightly referred to ocular oncology. The patient by this time was 24 years old and remained asymptomatic. There was clearly documented growth as shown by the sequential photography, and by this referral, the ultrasonographic thickness was 0.6 millimeters, so still a very small lesion. Clinically, it had a diameter of more than 2 disc diameters, so just over 3 millimeters. The calculated mole score for this lesion would be 5, and that's because although there is not obvious orange pigment overlying the lesion, autofluorescence reveals copious orange pigment within the puddle of subretinal fluid inferior to the lesion. TFSOM has 2 risk factors for this case. So this brings us to our final poll. What would you say the diagnosis was now, and what would be your management? Would it be A, a benign nevus that you would monitor locally in a non-specialist department? B, a suspicious nevus that you would monitor in a specialized surface? C, a possible melanoma, and would you offer a diagnostic biopsy? Or D, a probable melanoma, which would require treatment? And when you're ready, we'll close the poll, please. So the majority of respondents thought that this was a probable melanoma and would offer treatment. In our unit, we discussed the patient at the Ocular Oncology MDT, and the decision was to offer prognostic biopsy and treatment, and she underwent proton beam therapy. I'd like to draw out some learning points from this case. Firstly, that all pigmented choroidal lesions need monitoring, preferably with serial photography. Whether or not this happens in the community or in the hospital service probably depends on your national situation. Nevi can, of course, grow, especially in young adulthood, but these lesions need to be monitored, and the growth should stop once the patient reaches maturity. Studies have shown that nevi can grow up to 0.4 of a millimeter per year, but that study had lesions with a mean diameter of 5 millimeters. It is probably more useful in these very small lesions to consider growth as a proportion of the original lesion. This lesion more than quadrupled in size, so that's clearly worrying growth. It also acquired 2 new risk factors, being the orange pigment and the subretinal fluid, which nevi should not do. The third learning point is that orange pigment and subretinal fluid can be distant to the lesion, especially in a dependent location. Autofluorescence is your friend. Be alert to this and look for it on the autofluorescence imaging. And then finally, should we treat these small lesions? We know from the small fatal melanoma study that lesions of 1 millimeter thickness and 3 millimeters of diameter can metastasize. And these small lesions can be biopsied and have been shown to have chromosome 3 loss, which is one of the lethal mutations. We would like to be able to monitor these patients more closely if we know that they have that lethal mutation. Thank you for your attention. Here are my references.
Thank you, Hibba. Very, very interesting case. So you actually raised another question in your medical history with the grandfather of having an ocular melanoma. So we would probably in Copenhagen have offered a germline determination for BAP1 mutations in these patients, and we would probably be more aggressive if you saw a nevus with growth, as you also were. But do you do germline mutation diagnostics in your facility?
Yes, we do. So for patients that we think have a high risk or strong family history or strong personal history, we do BAP screening. And that was something that was offered to this patient.
Okay, and just of interest, was it positive or did you have a mutation?
We haven't had it back yet. This patient's fresh off the press.
Okay, because it is really a problem with these patients, young patients with melanocytic lesions, and they have a predisposition for the TDS. How should we follow these patients? But this is the subject of a completely different talk. I don't know if you other panel have anything to add to this case.
Yeah, I would like to come in to Carol. I mean, why we think this is a melanoma, because of the growth. And the growth really doesn't fit, obviously, if we see a patient for the first time. But during the follow-up, does growth play an important role in your practice? Where does it come in?
Yeah, an older study that we published back in the 1990s, patients with small lesions that showed growth had significantly greater risk for metastatic disease compared to those that didn't show growth. In a case like this, we would have drawn BAP1 the day we met the lady. We've had similar cases to what Hibba showed. Small, non-suspicious choroidal nevus in a patient with a relative who had a melanoma, and that this person tested positive for BAP1, and sure enough, the tumor grew. We published that in Retina this past year. It was the first case that we had seen where a really non-risky looking nevus turned into a melanoma in a patient with BAP1 germline mutation. Very important.
Looking at the growth, Bertil, over 2016, 18, and all these pictures, at what stage would you have thought, would you perhaps with hindsight again, would have thought at an earlier stage that could be something, or do you need more risk factors like orange pigment and fluid definitely developing other than growth to really do something? What would you say?
You don't get orange pigment and subretinal fluid until the RPE is disturbed, until the function is disturbed. And for that to happen, you have to have a certain amount of growth. And before the growth occurs, or before this tumor reaches a certain size or a certain rate of growth, then you won't have orange pigment and subretinal fluid.
So I'd like to make a comment about growth. Years ago, when we looked at slow enlargement of choroidal nevi, we found slow enlargement significantly occurs more likely in younger patients than older patients, as Hibba mentioned. And it's the rate of growth. It's very, very slow. And it generally, the maximum you're going to get in slow enlargement and still remaining a nevus by our judgment is you'll get maybe maximum 1 millimeter of enlargement or less. That's so if we saw more rapid growth or additional risk factors, we would have been very suspicious. I suspect by the first or the second year follow-up, we would have been very suspicious here.
And can I follow on?
This is the comment that I would also like to make. The dynamic of growth, I think it's extremely important. If the dynamic is more aggressive of growth, Carol just mentioned it, I would be much more suspicious of having a high-risk nevus or even a small melanoma. So in my judgment, probably in this case, in the third time of checking the patient, I probably would have gone for treatment. I don't remember what year this was, but I think it was a third photograph that I saw, which I think, in my judgment, was a significant change in size.
Nikos, do you ever see a nevus grow in a 60-year-old? Or do you think it's always a melanoma?
Of course, we can see a nevus growing in the 60-year-old, even in older patients. Yes, we do.
So can I ask you, Carol, a question, whether having more than one nevi in an eye, is that a risk factor or is just that coincidence? Should we follow these patients differently?
Not a risk factor for transformation into melanoma. And when we did a big analysis years ago, we looked at the clinical spectrum of choroidal nevus, and we found 3 things happen over time. Number 1, the nevus over time can become slightly thicker. I'm talking a fraction of a millimeter. And over time, of course, it gets more drusen and RPE alterations. And over time, as you follow patients, you're more likely to see multifocal nevi over time. So the fact that a patient has more than one nevus doesn't mean they're at greater risk for one of them to turn into melanoma, based on our analysis.
Thank you.
And maybe another comment, if I may. If the patient is younger and we see an enlargement, this patient, I think he was less than 30 years of age. It is highly improbable that this patient will live his life without developing a melanoma if we see in the first 2 years of his life that there is an enlargement. This would be completely different, I think, in my judgment, if this patient was 60 or 70 years of age.
So I'd like to ask one question for all the panel discussion is family disposition. Does that make any concern to you? Would you follow a patient differently if you knew that there was some kind of family history of malignant melanoma in the eye? Or would you just follow the normal rules of moles and TFSOM?
Family history plays into our management. If there's a family history of uveal melanoma and a patient comes in with a melanocytic lesion that we judge to be a nevus, we would probably follow them maybe a little more tightly and offer them BAP1 germline testing if they want it. We would strongly suggest BAP1 germline testing if we see that the pigmented lesion had enlarged in the patient we were following. So yes, we would probably see them back in 4 months just for peace of mind, and then perhaps twice yearly thereafter, if there's a family history of uveal melanoma.
So Hibba, what would you do in Moorfields?
So I think that's a very fair comment. When there's a very strong family history, we are more worried about those patients. To my knowledge, I don't know whether we've actually offered BAP1 testing prior to a diagnosis of melanoma, but I'm not sure Professor Damato would be able to answer that better. But we certainly do take that into consideration when we review these patients.
I don't think we do it prior to the diagnosis of melanoma, but in a patient who, as young as this, even without a family history, I understand there's an indication for BAP1 testing too, isn't there?
What about you, Niels? How do you treat these in Leiden?
Yes, well, I think it's quite the same as the things Professor Shields just told. So if there are indications for germline BAP1 testing, then of course we would offer that to the patient, but that would not so much influence the treatment for the patient itself.
So we typically offer BAP1 testing when there's a family history of melanoma. And if the patient or someone in their family had renal cell carcinoma, mesothelioma, or if they're a super young age with melanoma, we tend to offer BAP1 testing. I mean, ideally, I'd like to offer it to everyone, but you know, financially, it's not feasible. We just have certain criteria that we have to see before we offer it.
We do that too, and we also do that and offer that option to patients that have multiple nevi, and in the very rare occasion that they have more than one melanocytic, even malignant lesions.
So I think due to time, we have to wrap up this session. I'm very pleased that you would all participate. I think you brought very important knowledge to the field. I'm happy to be from EURETINA presenting this important event. So thank you, everybody. It was a pleasure to hear you talk, and we have some very good questions from the Q&A. We will try to answer them before we upload the session. It can be viewed afterwards on the webpage from EURETINA for the people who wasn't lucky to be here live. So thank you, everybody.
Thank you. Thank you for your participation.
Thank you very much.
Thank you. Bye.
Bye.
Thank you.